It's just on 1 o'clock, so we'll begin. Welcome. This is our first policy and research webinar for this year, a collaboration between LGBTIQ Health Australia and the Butterfly Foundation. So the LGBTIQ Health Australia is the national peak organisation working in Australia for the health and well-being of lesbian, gay, bisexual, trans, intersex, queer and other sexually and gender diverse and bodily diverse people. And the Butterfly Foundation works to change lives by providing support services, treatment and resources, delivering prevention and early intervention programs, and advocating for the needs of those people with eating disorders and body image issues. My name is James Zanotto. I'm the Policy, Research and Communications Director at LHA, and my pronouns are he, him. LHA acknowledges the traditional owners of country throughout Australia, their diversities, histories and knowledge, and the continuing connection to land and community. We pay our respects to all First Nations people and to elders of past, present and future generations. Now, please feel free throughout to use the Q&A function if you'd like to ask any questions. We'll have a presentation from Tanya, and then I'll invite Chantal in to join the conversation. And at that point, we'll open it up to your questions. So before we begin completely, a couple of housekeeping items. First of all, we are recording today, and the recording will be put onto the LHA website for future reference and people who missed it. And secondly, this webinar may touch on themes that some people will find distressing. If you need help, you can contact QLife, which provides Australia-wide anonymous support for LGBTIQ+ communities. QLife services are free and include both telephone and web chat. You can also contact Butterfly's National Helpline, which is also free and confidential, and has specialist counsellors for non-judgmental support by phone, email, or online chat. So without further ado, let me introduce you first of all to Tanya. Dr. Tanya Nichols is the clinical supervisor of the National Helpline at Butterfly Foundation. And as clinical psychologist and clinical supervisor of the helpline, Tanya is experienced in and passionate about the treatment and prevention of eating disorders and body image concerns across the lifespan. Tanya's awareness of the lasting impact of eating disorders on individuals and their families motivates her commitment to promote understanding and early identification of eating disorders. So without further ado, Tanya, across to you. And if you could pop your presentation up, that would be great.
Thanks so much, James. I'll just take a moment to share my screen and we'll be good to go. Let me just see. Now, just make it a little bit bigger. Here's the thing. Can everyone see that? James, can you give me a little thumbs up? Good. Okay. So welcome everyone. I thought that today it might be really helpful for us to start off with a little bit of background on what eating disorders are and where they sit in the landscape in Australia at the moment. So eating disorders are very serious and complex mental illnesses that are characterised by physical and mental health complications which may be severe and life-threatening. They're characterised by disturbances in thoughts, feelings, behaviours towards body weight and shape, and or towards food and eating. Now, no one factor can explain the development of an eating disorder. Eating disorders are actually caused by a combination of factors that include biological, psychological, and sociocultural factors. They're potentially very dangerous, and if left unaddressed, the medical and psychological and social consequences of eating disorders can be severe, enduring, and life-threatening. So let's look at this in a little bit more detail. Just a few facts that we might not be aware of. Eating disorders have the highest mortality rates of any mental illness. That's largely due to suicide and also physical complications of the illness, like cardiac concerns. But suicide is a major cause of mortality for people affected by eating disorders. At the moment, eating disorders impact over 1 million Australians every year. But of those, only 23% of people with eating disorders actually seek professional help. I think that's just an outstanding statistic and speaks to the level of stigma and shame that surrounds these illnesses. Over a third of people who experience eating disorders are male. And concerningly, people identifying as LGBTQIA+ are disproportionately affected by eating disorders. And we'll talk more to that in a moment. But let's take a look first off at just some of the general risk factors for eating disorders. So I said before that biological, psychological, and socio-cultural factors interplay to contribute to the development of eating disorders. So among the biological factors, we're talking there about genetic risk factors, as well as things like family history of eating disorder and other mental health concerns, and medical conditions like diabetes and celiac disease. Among the psychological factors, we're looking at things like anxious and perfectionistic, obsessive, and kind of rigid personality traits. And among the sociocultural factors there, we're looking at body dissatisfaction, a very significant risk factor for eating disorders, and social environment. By that, we're talking about family, peers, and of course, the media and social media influences that are so prevalent. We're also looking at external and internal pressure to adhere to the prevailing lean and muscular appearance ideals. And as well, engaging in occupations or activities that emphasize weight and shape requirements. And that might be things like dancing, horse riding, even bodybuilding, and certain occupations like modeling, for example. So there are numerous health implications associated with eating disorders. And these can include cardiovascular, gastrointestinal, neurological concerns as well. Eating disorders also impact cognitive and psychosocial functioning. And through that, it can result in diminished concentration and decision-making difficulties, significant mood concerns, social withdrawal, disability, and as we said previously, increased risk of death due to medical complications and suicide. So I love this image because to me, it just speaks to the diverse range of eating disorder presentations. If we look at that image there, a lot of the times, certainly in the past, when we think of eating disorders, we might have thought of a young, adolescent, white, very thin, malnourished female. But what we know now is that eating disorders can affect anyone, regardless of gender, regardless of age, race, or socioeconomic status. So all of the people in that image are affected by a serious and life-threatening eating disorder. The other thing that really jumps out at me there is size, body size. You cannot tell just by looking at someone whether or not they have an eating disorder. Eating disorders present in lots of different body sizes, as you can see. They don't discriminate. So I'm just trying to move my little, sorry, I've got all your images sort of obscuring the stats there. But if we look at the specific stats, you might be surprised to know that anorexia nervosa makes up only 3% of eating disorders in Australia. Bulimia nervosa, 12%. And this other eating disorder, other specified feeding and eating disorders, AusFed, encapsulating 38% of eating disorders in Australia. And that's an interesting one because it kind of encapsulates sometimes subclinical presentations of eating disorders like bulimia nervosa, where an individual might meet many of the DSM criteria for the eating disorder, but might not meet full criteria for clinical diagnosis. It also encapsulates what we refer to as atypical anorexia nervosa, whereby we might see presentations of people who, they have every single symptom of anorexia nervosa. They're medically unstable, extremely malnourished, extremely underwell, extremely cognitively, psychologically compromised, and yet their weight might remain in what, we might not see as being, by BMI standards, a significantly underweight. Yet they're experiencing every single symptom of anorexia nervosa. And we might talk a little bit to that later. There might be some questions, but looking at the stats there, 38% are presenting in that way. And it can be really tricky for people, particularly presenting with atypical anorexia, when at times there's little understanding of that presentation. Also looking at that binge eating disorder, 47% of eating disorders in Australia. The good news out of all of this is that with effective intervention, the prognosis is good. Full recovery and good quality of life can be achieved. So let's move on and talk a little bit about what all this means in terms of body pride. And I'm just checking the time there to make sure that I might need to speed up the process a bit. Okay, so with preparations for WorldPride 23 and other LGBTQIA+ events across Australia, there's been increased focus on body image concerns for many within the community. So we're seeing a seasonal spike in body image pressures, and this is found to lead to really harmful and disordered eating behaviours. Many people within the community are preparing for these occasions and potentially engaging in really dangerous crash dieting and excessive exercise, which has commonly become known as the Mardi Gras shred. So Butterfly conducted a body pride survey, collecting the insights of over 1,000 LGBTQIA+ individuals. So let's take a look at just some of the results of those findings. So something that really sticks out is over half, or 54% of people in the community believe that there is an expectation to look a particular way to be part of the LGBTQIA+ community. 2/3, or 64% of gay men believe there's an expectation to look a certain way. And I'll just pick out one more back there. You can look at them at your leisure, but nearly half of the community say they experience increased body image pressures in the lead up to major community events like WorldPride. So, what else do we know? People who identify as part of the LGBTQI plus community experience greater incidence of eating disorders and disordered eating behaviours, more severe symptoms, and much longer delays between diagnosis and treatment than their heterosexual cisgender peers. Homophobia, transphobia, gender dysphoria, discrimination, bullying, trauma, abuse, concealment of gender identity, and alienation from friends or family members also results in high levels of emotional distress, which, in addition to some of the other risk factors that we talked about earlier, can contribute to body image issues and eating pathology. And there's just a couple more stats there. US research indicates that more than half LGBT adolescents have been diagnosed with an eating disorder in their lifetime. And we estimate that numbers in Australia might be similar, but there's a real need for research to be directed towards the diversity of people who develop eating disorders to gain further understanding around this. So what can people do? Butterfly Foundation has partnered with Instagram to launch WorldPride, a campaign specifically designed to address and challenge negative conversations around body ideals and appearance that can spike in the lead up to LGBTQI plus events, particularly Mardi Gras. So some of the things that we can do here is people on social start to follow some people on social media accounts that make you feel negatively about your body or identity. So unfollow those accounts, and perhaps diversify the feed. So follow a variety of bodies and appearances so that you can start to feel content. See content that makes you feel more body confident, empowered, and inspired. I like the next one, make connections and not comparisons. Social media, great for making connections with like-minded people, but avoid those comparisons because compare equals despair in a lot of cases. And avoid filters. Showcase the real you. So just finally, let's take a look at what some of the signs are of an eating disorder. And there's lots of things, so I'll just pick out a few there. One that might stick out to most people is weight change, either a decrease or an increase in weight. Also, as we said earlier, body dissatisfaction, significant changes to diet and eating behaviour, and cognitive rigidity around lack of flexibility around eating and eating behaviours. Things like feeling faint, dizzy, increased fatigue, misuse of supplements, anabolic steroids and performance-enhancing drugs, laxatives, diuretic, appetite suppressants, and things like social withdrawal, heightened anxiety and irritability around meal times, and perhaps signs of self-induced vomiting or frequent trips to the bathroom after meals. Big ones to be aware of: depression, anxiety, self-harm, and suicidality. So if you or a loved one starts to experience some of those concerns, it's important to speak to a trusted loved one. Butterfly's website has a great range of resources and information that you can access. There's also Butterfly's helpline. We do recommend that you ask your GP for a referral to a psychologist and a dietitian. And your GP can actually prepare a mental health care plan or eating disorder treatment plan to enable subsidised mental health care. You can find psychologists, dietitians and other treatment professionals by searching Butterfly's referral database, and also Australian New Zealand Academy of Eating Disorders, ANZ AED, their ConnectED database, to find a credentialed eating disorder clinician. Just a few notes on what clinicians can do. Clinicians working with the community must thoroughly assess for disordered eating behaviours, in addition to any proximal or distal risk factors present for eating disorders and disordered eating behaviours. Our clinicians really need to become skilled to respectfully interact with the community so as not to perpetuate the stigma that so many people have already experienced. And likewise, educators should also be informed of eating disorder risk factors for individuals within the community and seek to provide an accepting environment for all people from sexual and gender minority groups. So just wrapping up, we understand that gender and sexuality are complex issues and unique to each individual, so we make no assumptions about your story and don't discriminate. So our helpline, Butterfly's National Helpline, the numbers there, is here for anyone who would like to chat or anyone with any concerns about a loved one presenting with eating disorder concerns. Okay, took a little bit longer than expected. There we go.
Thank you so much, Tanya. What I'd like to do now, Tanya, if you stop sharing your screen, I'd like to draw Chantel into the conversation and formally introduce you to everyone. Chantel is an ambassador for the Butterfly Foundation. They work as a health promotions officer at UNSW with a focus on improving mental health literacy and advocacy for student well-being. They're queer, non-binary, neurodivergent, with a lived experience of disordered eating. Chantel's also trained in sociology and anthropology and gender studies. Their interests lie in how power dynamics and social structures play a role in how we form our identity and how those identities can be policed through policy, social norms, and violence. So welcome, Chantel. And if I could, I'll invite everyone again to put their questions into the Q&A function within Zoom, normally at the bottom of your screen. But I'd like to put the first question to you, Chantel. Could you start by talking with us a bit about what's your advice for healthcare and service providers? How can they help people manage body image concerns and create a safe space for everyone to receive compassionate and effective care?
Sure. First of all, I just want to thank Tanya for that presentation, for talking about such a heavy subject in a really compassionate and open way. And I really hope that everyone got everything that they need out of that presentation. In terms of how practitioners can better assist people from diverse communities, from the LGBTQIA+ community and beyond, I think just understanding that people are multifaceted is a really important first step. I know the pressures that are under health practitioners in terms of how many patients they have to see and, the very complex situations that they're often faced with. And I think it's very easy to slip into kind of a routine of just ticking off boxes of asking people important questions to kind of move through the motions. But I've been in many situations where practitioners have kind of steamrolled through this kind of script that they go through and talking about topics that are honestly quite triggering and quite offensive sometimes, that can really be a huge blocker to people getting the support that they need. It takes an extreme amount of courage and strength to be able to ask for help from a health practitioner or anyone within their support network. And unfortunately, having a negative experience can be the difference between someone getting the help that they deserve and need now, and either getting it when it's too late or never at all. A lot of the times when people do get to the point where they are asking for help, they've been thinking about this for years. They've been looking at their situation and understanding how it's impacting their life. And, it's not just they woke up one day and be like, I'm going to go speak to my doctor about my body image issues. It has been debilitating for them for a long time, and they're realizing that it's impacting their relationships, their job, their studies, their sense of self, even the way in which they see the world and move through the world. And so really just understanding that people come from multifaceted lived experiences, and being open to understanding that instead of making the assumption based on how someone looks, what socioeconomic background they come from, what cultural background they come from, or what gender and sexuality they identify with.
Thank you, Chantel. Tanya, can I sharpen the question a little bit from one of our participants? And just before I do, can I thank the person who said we should have all shared our pronouns? I did mention mine at the start, but I've just noticed that I've entered in using an admin account today, so it wasn't in my name. So Tanya, as you respond to this question, could I get you to let us know your pronouns? But the question is, can we specifically talk about what interventions you found to be most effective?
Thanks, James. Well, I'll start off by sharing my pronouns. My pronouns are she, her. Interventions, well, I think first and foremost, I just want to take up a little bit on what Chantel said about the need to treat people as individuals. One intervention is not a one-size-fits-all, and there's certainly diversity in the eating disorder community as a whole, and diversity within the LGBTQIA+ community, and that really needs to be understood and recognised. Now, in terms of eating disorder interventions, now I'm going to talk about blanket term interventions. When we're working with adults, the main treatment focus is usually from a cognitive behavioural perspective, and trying first and foremost to get people back into a regular eating pattern, so that then they're more nourished and able to do some of the cognitive behavioural work that is really, really challenging. But, with that blanket sort of intervention, also taking into account that person's lived experience and the individual risk factors that have led to their presentation, and incorporating that into treatment. As Chantel said, actually, I spoke to someone, I did a single session intervention with a young person yesterday from the LGBTQIA+ community. They were, I think, in their mid-20s, and it was the first time they had raised, concerns about body image and eating disorder that had been going on since their teens. So it just speaks to, the importance of that.
Thanks, Tanya. I've got a couple of comments I'll pass on, sort of thanking you both for sharing and saying that they've learnt a lot. Tanya, I've got a quick question asking whether you're willing to share your PowerPoint with participants today.
Absolutely. Yes.
Thank you. Chantel, the next question is for you, if you feel comfortable to respond to it. Someone asking if you could elaborate on what sort of questions or styling of questions that you've had that you're aware of that are triggering, saying they'd absolutely want to avoid that and seeking some advice.
Yeah, absolutely. I think just generally any kind of comment on weight and weight loss, unless brought up by the person themselves, is something to avoid. I have been in lots of situations where I've come in. I also know a lot of other people who have gone in for any number of other issues, whether it be a cold or something, and then all of a sudden their practitioner starts talking to them about, oh, so this is what you need to do to lose weight, let's get you set up with a nutritionist, all that sort of stuff, which, you know, they've done no kind of screening to see if they have a history of disordered eating, or treatment of eating disorder, or even just asking, like, where are you at with your body image right now? Like, is this something you're comfortable talking about right now? Kind of putting a disclaimer, and approaching it without the assumption that that's something that they're automatically striving towards just because they sit somewhere on a BMI scale. The BMI is another one that practitioners still use, even though it's been like clinically thrown out the window. And also when it comes to the LGBTQIA plus community, I think a lot of people come forward with a lot of really good intentions, but maybe not a lot of education, especially within the trans community. There's the saying of like the trans broken arm of a doctor will go in, a patient will go in with a broken arm and the doctor will all of a sudden be talking about their gender just because they so happen to be trans. And somehow people's identity just like completely become about their gender instead of seeing them as like a whole human being. So any invasive questions about genitalia, like dysphoria and things like that, learning how to navigate those topics is really important, and having access to that training is just vital. I know that there's not a lot of resources out there, but there's great resources like Trans Hub that are specifically within the New South Wales context, but they're expanding this year to be a national resource that have incredible resources for practitioners and even just the general population who want to learn more about trans identities and language and health services.
Thank you, Chantel. We've got a lot of questions here, so I'm going to plow on with a couple more. I'm not sure who this one is best to, but perhaps you, Tanya, feel free to dive in, Chantel, if you have information. We've got a question from someone who works in regional outreach and wondering if there's any differences between communities in rural and urban areas.
I wonder if we could clarify that question a little bit. Is there any difference in communities in terms of access to services? There's definite differences. Very, very challenging to access eating disorder treatment services in regional and rural communities. And I can imagine it's
definitely,
challenging.
Tanya, challenges across the board on health and access. I'm reading the question though more as in how eating disorders affect people in those areas.
I'm happy to jump in for a little bit on that if you want to think on it, Tanya. I think just from a community perspective as a queer person, regional Australia doesn't necessarily have a large population of openly queer people who are visible, who are active. Of course, there are certain areas where there are small networks and things like that. And just having a support network can make such a huge difference in someone's life, whether it be for their disordered eating, their mental health, even just their sense of self and their identity. So I think definitely some of the challenges within regional areas would be access to community, access to the same like-minded lived experience people, so that you feel like you have a mutual connection with that you can confide in, and then also access to specific support services and like general mental health and medical practitioners that are either specifically for the community or at least educated on. It can be really challenging sometimes navigating the medical system, not knowing if I'm about to drop $600 on seeing a specialist who's going to misgender me the entire time or completely just like dismiss me because of my queerness. So that's also another thing of just like having visibility around how to navigate the system and whether or not it's a safe space.
Thank you both again. Just ploughing through these questions, which are coming in thick and strong. I've got a question here about LGBTIQ young people in schools. Any suggestions for supporting them for educators?
That's a really tough one, especially because we've just come out the other end of the education legislation amendment policy of last year. And I think that there are lots of new challenges faced for educators as to how they can navigate their institution within like protecting themselves and their career. And I think the best thing is education, making sure that you are educated and not just being like, I don't care if queer people exist near me, that makes me an ally. Being an ally is an active participant. It's not just a passive thing of like, that's fine, queer people can exist. It's about understanding how they navigate the world, the challenges that they're faced with, and making sure as well that you are visible. Having a visible ally or a visible queer person can make such a huge difference in a young person's life. I went to very strict private religious schools, and I knew I was queer very young, and had to navigate that space and have witnessed other people be expelled from schools. And that message was given very clear to me that like I was not able to exist within that space. So just even as simple as a rainbow flag somewhere can be an incredible symbol to someone. And if you know a child is queer or they come from a rainbow family, just checking in on them to make sure if you know something's going on, or if the environment that they're in may not be super conducive to their existence, just making tabs, touching base with them, checking in if they're okay, and if they need even just to sit in the classroom at lunch to avoid any bullying or further isolation can be really helpful.
I suppose to really extend on that too, becoming more educated about some of the unique risk factors for people within the community around body image and eating concerns, and being able to, recognise and perhaps help to intervene early if someone is struggling. Yeah.
Thank you. So helpful. I have a follow-on question a little bit here, and a cluster of questions. Someone said, hearing other queer people share their stories of eating disorders can be very powerful in feeling not alone. How can we facilitate more storytelling and peer support? And I have a cluster of questions very much around peer support and how to use it and encourage it. Could I ask both of you to comment on that?
You want to go first, Chantal, or not?
Sure. Like within the context of my work within the university space, I actually run a few programs called Untold Stories about facilitating students and also staff, so that students have a representation of staff who have, faced mental health challenges or adversity and things like that, so they can see themselves reflected. And just making sure that the resources are available there, and making sure that you're doing it in a trauma-informed way is probably one of the most important things, because you don't want to traumatize the person telling the story. You want to make sure that the person telling the story is in the right place, then they're not going to say anything that they might regret later, especially if it's open in the public space, depending on what they're talking about. And also making sure that the way in which they tell their story is not facilitating any harmful behavior from the people that may be consuming it. And also Butterfly do incredible work on making sure that people have the opportunity to tell their stories by making blogs, video content, and getting people involved in campaigns. And I've been lucky enough to be a part of that. And there's some incredible people a part of Butterfly who do such great work and share such diverse stories and lived experiences. And in terms of peer support, setting up programs where you are building people's capacity, improving their health literacy, and making sure they feel confident to navigate a space and know to operate within their scope. I think especially if someone has a lived experience, they can often be really passionate about not wanting someone else to go through what they went through, and they can often take a lot on and kind of operate outside of their scope. And so it's really important to be able to build people's capacity up, but also let them know that, like, to operate within certain boundaries and give them guidelines as to how to refer people on, when to refer them on, and how to identify warning signs. That's something that we do a lot at UNSW, and I know Butterfly do that as well with everyone involved in their campaigns. And there's lots of programs available that you can kind of build into your institution or your workplace in order to facilitate that.
Yeah, Butterfly has moved towards a peer-led model with our recovery support services as well. So support groups like the Emerging Group, carer support groups, and we have individual peer-led support as well, which can be really helpful.
Thanks, Tanya and Chantel. I think we're starting to run close to time, and I can see there's no chance at all I'm going to get through all of the questions that are here at the moment. So I just want to touch on to a couple of different ones in the few minutes that we've got left. I have one question about clinicians, mentioning specifically dietitians, but the question I think is broader. What can they do in their clinical environment to make people feel more comfortable?
I'm going to take up a couple of the things that Chantel said there, even having the little rainbow flag advertising, that the practice that you as a practitioner welcome and have experience and expertise in working with the community. I think that goes a long way. Also, being curious, not making assumptions, as I think Chantel highlighted. We really ought to be curious about everyone who comes to our practice, but I know that's not always the case. So maintaining the curiosity and openness and asking people how they would like, being collaborative in your work with people.
I think collaborative is such a great word to talk about. I think there is a very obvious power dynamic within the patient and practitioner situation, which I think if you can acknowledge that and understand how that plays out in people's lives, like we are talking about people's lives here. And when you feel small and you feel unempowered, it can be really helpful to have someone who is in a position of power to make you feel empowered to be the arbiter of like your own story and take part in your treatment. I think one of the things I love the most about my GP is that he works so collaboratively with me to the point where, I'm very lucky that I have access to a lot of academic things, and I read medical journals for fun sometimes. And so, I do a lot of research in terms of navigating my own health. I have a lot of comorbid chronic health conditions. And I've literally just started medication last week that I found through TikTok. I researched myself, and then I came with all the research to my GP. He went off, he did his research, and then we came back and we collaboratively made a care plan. And that makes me feel so seen and so heard, and makes me feel empowered to take care of myself instead of feeling as though I am disenfranchised to leave it up to someone else who knows nothing about me, sees me maybe once a fortnight or once a month, and is the barrier that I have to go through in order to get support, especially if you're looking at like financial support as well of going into the public stream. So yeah, I think just like acknowledging the power dynamics and working collaboratively with people and making sure that they walk out of there feeling empowered instead of feeling deflated.
Really good point, Chantal.
Thank you, Chantal. And I think that's probably a wonderful spot for us to close up. I'd like to thank everyone for all of the questions, and we haven't gotten through them all. It's been great. I've learned a lot as well, and really enjoyed hearing from both of you, Tanya and Chantal. I'd like to thank you very much. I'd also like to do a brief thank you as well to Zoe and Kate and Melissa at the Butterfly Foundation, who's helped us put today together in the background. And I'd like to thank Andre and Paula from LHA, who have helped in the background. But most of all, I'd like to thank everyone for attending and for caring and for listening. And I hope that it's been incredibly helpful for you. Just a reminder, if you do need to talk to anyone about this further, there's QLife, 1-800-184-527 or qlife.org.au. And there's the Butterflies National Helpline, 1-800-334673, or butterfly.org.au. I'd also like to point you particularly to the butterfly.org.au website. You'll find stories of people who are sharing their experience. You'll find information about the WorldPride campaign that Tanya mentioned in her presentation, and you'll find other helpful information also targeted towards LGBTIQ plus people. So thank you again, and have a good day.